Hi everybody, good afternoon. Welcome to our webinar today. Today we are doing, oh goodness me, I've just lost my flyer. Today we are doing quality improvement in chronic kidney disease in general practice. Our presenter is Deborah Wolgansky. She is a registered nurse and midwife and is also a primary care improvement officer for the Primary Health Network, and she is a special matter expert on chronic kidney disease. Before we go any further, I'd like to acknowledge the traditional custodians of the land that we're meeting on today and pay respect to elders past, present and emerging. I will put in a link at the end of the session for you to fill out an evaluation through Slido. If you have any questions, you can type them in the chat box, or alternately, at the end of the session, you can use the reactions box that has a little hand symbol. You can put that up, unmute your microphone and just ask the question. But I think we're going to do all of that at the end. So we are recording the session, so it can be available in our library afterwards. All right, thank you, Deb. I'll hand over to you.
Thanks very much, Jenny P, for the warm welcome. I'm just going to share my screen. And thanks everybody for coming along to this one. It's pretty exciting. I think there's someone waiting in the lobby there, Jen. Okay, so this is about chronic kidney disease. As Jenny said, I'm Deborah Wolgansky, a primary care improvement officer at the PHN. So today we're going to go over some content. It goes pretty quickly. So some statistics that are pretty compelling, some quality improvement activities that the PHN have designed. We'll look at some chronic kidney disease risk factors, look at the kidney health check, talk about diagnosis a little bit, and staging of the disease, looking at clinical action plans across the practice, and then also looking at some monitoring and management. So I guess the big news flash is that dapagliflozin's been the first kidney disease drug listed in over 20 years on the PBS. So you can see it's on a lot of websites, including the Deniliquin Pastoral Times, which I thought was pretty cool. That's Malandiri McCarthy, the senator, talking about how this medicine will help thousands of people. And we know that it's overrepresented as a disease in the Aboriginal and Torres Strait Islander population. So it's on the PBS. $6.80 now a script. It does slow the progression of kidney disease to prevent a patient reaching kidney failure. It was utilized in diabetes and heart failure. It's now been indicated for prescription for patients with CKD. And so I guess the burden that could be alleviated is 45,000 Australians, including reducing 17,000 deaths. So I'm pretty excited about that. That was just August, September that happened. So I did want to show you the compelling reason for why we should be worrying about chronic kidney disease. These are the 31 PHNs across Australia. This is from the Australian Institute of Health and Welfare. So adults with kidney disease, our PHN boundary, we are the fourth worst, down the bottom in the dark blue. For hospitalization rates, persons within our boundaries are the third worst in Australia. Mind you, these are crude rates. They're not age standardized, but nonetheless, it does show you how important it is. And for death, we are second worst. So a lot of work for us all to do out there in primary care and in nursing. So this is a local government area map of New South Wales from Health Stats New South Wales. So the dark blue is the worst performing areas per 100,000. This is age adjusted. So Cessnock, Gunnedah, Moree and Tamworth, these rates are all worse than the all New South Wales LGA rate. and we're in the top 10 with some other unfortunate LGIs. So yes, a compelling reason for why we should be worrying about this. So the PHN have put together a general practice summary, as you're probably aware, in your practices. If you're participating in the Penn CS Cat 4 PHN sponsored license that we provide. So we do show you on the reports the disease prevalence. For example, in this practice, there's 135 persons with chronic renal failure, which is the old term for chronic kidney disease. So one thing I wanted to point out on our reports is we do let you know Cat 4 will look at pathology, and the pathology is indicating that a person, probably or maybe has chronic kidney disease, and yet there's no diagnosis in their patient record. So this particular practice, dummy practice, by the way, has 369 persons that have some sort of pathology on their file that's indicating chronic kidney disease, and yet they've not been diagnosed. So they actually are quite invisible. Like if we were to search for patients with kidney disease, they would not come up. That's a lot of people for one practice to be flying under the radar. Some of the other things on our dashboard are comorbidities. So we do show you the prevalence of diabetes and also hypertension. As you know, those are comorbid with chronic kidney disease. Some of the other things we show you are about ethnicity. And so this particular practice you see has 163 Indigenous patients. But concerningly, there's 157 patients in this practice whose ethnicity is not recorded. And so as I show you a bit later, ethnicity can be a risk factor for chronic kidney disease. And so it's really important that we record that ethnicity so that when we look for risks, they do come up and they're not invisible. Some of the other things are lifestyle risks. So obesity and smoking are both associated with chronic kidney disease. This particular practice has a lot of patients whose weight or height has not been recorded in the right spot in the software, such that a BMI could be determined, 1,800 persons, in fact, and smoking similarly, 1,100 persons in this practice didn't have smoking recorded. So in regards to the Aboriginal and Torres Strait Islander persons that you have identified in your practice, they can have a health assessment. Colloquially, we call it the 715 assessment, but it really is an Aboriginal and Torres Strait Islander people's health assessment. So in this case, this practice has 132 not recorded, which is opportunities to discover chronic disease really is the reason for this health assessment. So it's important for chronic kidney disease. The other report I wanted to show you about is the LUMOS program, and this is a partnership between New South Wales Health and primary health networks across the state, such that there's data linkage between the patient's record and the general practice in a de-identified sense. There's no names accompanying it. But that's partnered with their data at the hospitals in New South Wales. And so you can get a report that shows you the chronic kidney disease admissions to hospital. You can see in this report, the practice is the orange ball. It also shows you this PHN with the green cross, and then all PHNs in New South Wales. So you can see how your practice is performing, because it might end up with admissions of either a main diagnosis or an additional diagnosis in the hospital. So that's kind of cool. If you want to get into the LUMOS program, just let your primary care improvement officer know, and we can get you an EOI and get you signed up. So the primary health network, we have developed 4 quarters of quality improvement activities. So this is great for practice. It's a real value add because of accreditation every 3 years, as you know. You do need to demonstrate a quality improvement activity to the assessors. And also for the quality improvement incentive payment. So quarterly, you do need to share your data from the PHN sponsored CAT license, and then also partner or work with or participate with the PHN in doing some quality improvement activities. You could use all 4 of these and do a 12-month program. So they are cumulative. It starts out with Q1, just identifying patients at risk of CKD. Then Q2 is identifying those patients that have some sort of pathology on their file and yet they're not diagnosed. Then Q3 is about providing chronic disease management, so a GPMP or a team care arrangement, some allied health visits, that kind of thing. And then Q4 is really using the Kidney Health Australia clinical action plans, which I guess you could think about them as a cycle of care. I'll show you a bit more about those. So yes, you could use those 4 for a 12-month cycle. A plan, do, study, act is a nice way of using improvement science such that you do get a baseline number and plan some improvement activities and then come back and review that number to see if you did get an improvement, what you need to tweak for the next quarter, and that you do sort of nut down on you know what the specific little activities are that you're wanting to attempt. So this is quite a useful document.
Still, I think
These that I've just showed you are all located on our Primary Health Network website. That's the address there in the top right. And just navigating around on our site, basically under what we do or under programs, you can get to the primary care support page. And then we have tiles that are for a lot of disease processes, such as cancer screening or diabetes or heart health, so that you can go to the chronic kidney disease one, and we do talk about the data and dashboard quality.
Yeah, you're on mute.
Is that better? Oh, great. Thanks so much for letting me know. I'm not sure what we missed. I'll keep moving along. So risk factors for CKD. So as per the chronic kidney disease management and primary care handbook from Kidney Health Australia. So diabetes, hypertension, as we talked about, cardiovascular disease, family histories of kidney failure, obesity, as we talked about, smoking, as we talked about, 60 years plus, but not of itself, only in collaboration with another risk factor, Aboriginal Torres Strait Islander origin, which we talked about, and then history of AKI or acute kidney injury. So in the CAT4 tool that you have in your practice, probably from the PHN, there is a CKD at risk report. So in your practice, you can identify the patient names, and that's really quite handy. And this partners with the first quarter's activity of patients at risk of CKD. So this is the report here. So it's targeted at 15-year-old and above who don't have a CKD diagnosis in the file yet, and yet they have one or more of these risk factors. So I guess the point is that these are the persons that you would run a kidney health check on. Maybe recall them or consider if, you know, with diabetes or hypertension that you'd like to do a kidney health check. So you can either click on the red legend on the right-hand side and get a whole list, or you can click on a part of the bar graph, either one of the red areas to get those names. So that's quite handy, really. So the kidney health check, I guess it's really important because 90% of kidney function can be lost before a person becomes symptomatic. And so the kidney health check is really a screening tool. And sadly, persons may not notice it until they reach stage 5 or dialysis. Sometimes they go on to dialysis pretty quickly within about 3 months of diagnosis if it's that severe. So it's pretty simple. It's a blood test, a urine test, and a blood pressure check. Pretty simple, really. So the indications and frequency for this, generally it's every 1 or 2 years, depending upon if the person has diabetes or hypertension, when you have those risk factors there. For Aboriginal and Torres Strait Islander persons, I just wanted to point out, as I mentioned earlier, that the 715, the Indigenous Health Assessment, is really a useful tool. From age 18, this is where you would screen for risk factors. So not exactly doing the kidney health check, but screening for risk factors. And then, of course, in the next box, you see that people 18 to 29, if you do have a risk factor, then yes, you would do a kidney health check. Certainly for persons aged over 30, you're just going to go straight to a kidney health check without screening for risk factor. And that should be done every year or two. So that's the frequency and the indication for it. So detecting it, there's a nice algorithm in the Kidney Health Australia guideline, basically, as we talked about there. I guess the thing is to know that if you do get a reduced eGFR or you get an elevated ACR, then you do need to repeat those tests twice more within the 3 months, such that chronic kidney disease diagnosis is really reduced eGFR or elevated ACR that lasts 3 months or longer. And so kind of what I think is, if you're going to do a kidney health check, just give them 3 urine pots and give them 3 pathology slips at the beginning. When the results drop in, the GP can say to them, look, just discard those other 2 tests. You don't need it. You've come off of the algorithm because they were normal. Or alternatively, they can say, look, I do need you to repeat that second one, and then that result will drop in. And then likewise, you'd say to them, I do need you to repeat that 3rd test. I just think that they're probably not getting back to get their 2nd and 3rd tests. And so why not just give them the path form with a date on it and a urine pot, 3 urine pots at the beginning. Okay, so diagnosing CKD. Right, so the Kidney Australia Handbook. So it's defined as an eGFR less than 60 or albuminuria that's present for 3 months or longer. There are some other things that will get you into the chronic kidney disease diagnosis. Things like structural abnormalities, pathology like tumors, hematuria, that you can't find the clause. So the cool thing with CAT4 is it will give you an indicated CKD report by name that's based on that pathology. And so that's really part 2, quarter 2 of the cycle, where we suggest that you find those patients and assess if they've had their 3 tests, and if you can, code them for their diagnosis. So this is a lovely, lovely graph that really spells it out quite nicely, that CKD can be due to loss of kidney function, such that the eGFR is decreasing, which will give you a kidney function stage from 1 to 5 in a worsening scale. And then albuminuria, you've got 3 categories: normal or micro or macro. And so when you partner those up with the eGFR, you end up coming up with the different clinical action plans. So, colloquially, we call them yellow, orange, and red. They do have different frequencies, which I'll show you. But this is a nice way of really deciding on where a person falls on this grid. And again, that green area, it's not CKD unless there's something that would have needed an ultrasound or biopsy or something. So to fully specify CKD, you do really need the 3 parts of it. You need the eGFR, you need the ACR, you do need the underlying reason for why this is occurring. So it's nice to note that CKD in itself is not the primary diagnosis and that attempts should be made to identify the underlying cause of CKD. So a full diagnosis would be something like stage 2 CKD with microalbuminuria due to diabetic kidney disease. So that's a nice way of phrasing it. I just wanted to go back to the coding a little bit, if I could. So the RACGP 5th Standards for General Practice Indicator 1.3a states that our practice team uses a nationally recognized medical vocabulary for coding. So that's something that's quite important from an accreditation point of view. But secondly, the eHealth PIP requirement for general practice, such that you upload shared health summaries. That requirement, number 3, is that a practice is using medical vocabulary that can be mapped against the nationally recognized disease classification. And so practices actually must provide a written policy to this effect. So I don't really see there's a lot of wriggle room here. You really do need to be using, for example, in medical director, the national medical vocabulary is called DOCL. In best practice, it's called SNOMED. Don't worry about that too much. It's in the background. But I guess the point is that you need to be using the drop-down coded diagnosis box or the pick from list box, not free typing, not hunt and peck typing and typing out a diagnosis. It's not coded. It's not searchable. The patient will be invisible. So this is the lovely CAT4 report. So we get into the data cleansing area. We go to the indicated CKD with no diagnosis report. You can click on the column headings to sort them, and I like to click on the EGFR and the ACR columns and get the worst at the top. You can see that the staging sort of happens automatically, such that you'll get stage 5 or red clinical action plans at the top. Just keep in mind, though, that the CKD stage is calculated using only the one most recent pathology report. And so you do need to click into the patient record and really peruse the pathology to see that they have completed the 3 tests. And then you can stage it through the diagnosis manually yourself in the record. You can also confirm the condition does not exist and take the patient off of this report. On the right-hand side, you just tick the box, push the save and remove button. They're always findable again by clicking on the reviewed tab on the left, so that you can see who you've reviewed and removed. But when new pathology drops in, they will reappear on this list if it's indicated. So that's quite a nice little activity. If you have top bar in your practice, it's super quick because you just double click on the patient name and it goes straight into medical director or best practice, straight into the patient record when you've got top bar in your practice. Another way of cleaning up these diagnoses that are free typed is either to go into best practice or MD, get into the cleanup history, find all the hand typed diagnoses, which is in this right hand box here. For example, in this case, the screenshot is of diab T2. And so what you would do is find the coded diagnosis in the right hand column and select that and push replace. That will automatically replace all patient records in the practice that have been hand typed with that diagnosis to the proper coded one. And you can see there's another one there, diabetes mel and diabetes. So that's a nice way of cleaning up all those hand typed diagnoses. And while you're doing that, or after you do that, you really should make that practice policy to stop that behavior from happening. Here's MD, same thing. You go into medical director maintenance, use the diagnosis coder. In this case, you can see it's been hand typed as ear infection. And then in the right-hand column, you start typing ear and you find the coded diagnosis, and then you correct those, and that will happen across all records in the practice. So it's very speedy. Right, so the clinical action plans that we talked about, the yellow, orange, and the red, you can see the yellow one is every 12 months, the frequency of that. For the orange plan, you can see that there's a plus in the middle there, such that you really would be doing all the yellow items of assessment and then adding on a bit more for the orange plan. This one is 3 to 6 months. I think that says under there. For the red clinical action plan, again, it's cumulative. You're going to add in the yellow, orange, and the red, and this one's 1 to 3 months. So I guess for the management items, the thing that's nice in the Kidney Health Australia guideline is they do talk about a whole of practice approach to CKD, so that you are getting allied health involved and nurses and Aboriginal health workers involved. This is a new report. I'm pretty happy. The RPHN advocated pretty strongly to PENCS that there really wasn't a report that allowed us a way of searching by stage for persons that were already diagnosed to get their names in your practice. We don't see it, but you can in your practice. The other thing you can do is you can actually use the legend to click on, for example, in this case, I've circled the red box, the clinical action plan, 1 to 3 months. And you can see that it's actually spread across 4 stages, stage 3A, 3B, 4, and 5. So by using the legend, you actually get all the names that would be needing a clinical action plan due within 1 and 3 months. So that's quite a natty little report that we advocated for fairly strongly. Yes, the kidney handbook talks about all the other issues that are common in CKD, and this is really where we can use multidisciplinary care across the whole practice. There are obviously MBS items for chronic disease management, and this is what quarter 3 is all about. This is about finding patients that don't have a GPMP or don't have a team care arrangement. They also may be needing case conferencing. They might need medication reviews, nurse and Aboriginal health practitioner monitoring, in between more structured reviews of the management plan and the team care arrangement, specialist referrals to things like psychology, dietitian, dermatology, respiratory, technician, pharmacist, nephrologist. So this is quite an important way of making sure persons do get the chronic disease management that they need. So that brings us to the management report in CAT 4, which is pretty exciting that you can see in one report how you're going as a practice for all the items.
Is Alpha Girl out the back here? Or? Yeah.
So quarter 4 is the quality improvement activity that we have to talk about that. So here's an example of the CAT 4 report. In this case, this is 15-year-olds and above who already have a CKD diagnosis coded in the file. And so you can see the management items of blood pressure, BMI, HbA1c if they're diabetic, cholesterol, smoking, whether they're on ACE or ARB, and statins. You can see in your practice where your strengths are. So obviously the green bits are the good bits. That person has had that assessment, or that they're even at target. Yellow is that they've had the assessment, but they're not at target. So that's nice to be able to find those patients who aren't at target. And then some medication prescribing there as well. So just to let you know, this is something in PNCS that tells you how those reports are mapped to. It will give you a little bit more information about each of the items and timeframes. So mainly it's over the last 12 months. So with the new medication, I just wanted to show you something kind of cool in CAT4 that you could utilize, given that this is now indicated for patients with CKD. This is the NPS page, and sadly, I just wanted to let you know that NPS funding apparently hasn't been renewed from 31 December. So if you wanted to go into that and get this dapagliflozin page pretty quickly before it goes away end of December, that would be a good idea. So in CAT4, what you can do, which is pretty cool, is you can go to conditions filter, select kidney disease. You can go to the medications filter, and it will be under anti-diabetic meds because that was the main indication for it previously. But if you tick no to the SGLT2 inhibitor, this will find you all patients with kidney disease who have not been prescribed that medication. You could partner it with the ACE and the ARB, mainly because the guideline states that they have to have been stable on that for at least 4 weeks before commencing on the other med. And so you could also go no for the ACE and the ARB, such that you could find patients with kidney disease who haven't had that 4 weeks yet of stability. And then you can partner it with the pathology report. So what we do is we select bits of the next graph, which is the pathology graph, that match the prescribing guideline. So in this case, an eGFR between 25 and 75. So you can click on either bits of the donut graph, or you can click on the legend as well on the right hand side. But what will happen is you'll end up getting oh sorry, this is the ACR page as well, so you would click on bits of that donut graph that match the prescribing guideline. But you can see that's what's happening is there's a little black dot that appears on the report baby tab. So when that black dot is there, that's when you're really going to get a cross-tabulated report. And so in CAT4, you just use this green report button, and that will give you a nice report with all the names. So I think that's kind of a natty way of getting persons to be prescribed for this new medication. Alternatively, you could use the CKD stage report to find these persons as well. So I guess to sum it all up, we had a look at some statistics in the beginning that were pretty compelling about hospitalization and death. We had a look at some quality improvement activities, had a look at some tools from the PHN, the dashboard, and the Plan, Do, Study, Act model for improvement. We had a look at some risk factors for chronic kidney disease and had a look at the kidney health check, what that entails. Then we had a look at diagnosis and looking at a complete diagnosis. We had a little look at staging and how that occurs, and then the clinical action plans and some monitoring and management. So I guess that's me, but if you had any questions that Jenny, I can't see the chat, Jenny, if there were any questions.
Got any questions in just yet? Just a comment of saying what a great session it is, and it's very helpful, which is lovely.
Oh, that's good.
I have everyone will notice, I'm just giving everyone a minute or so just to type in any questions if you have them in the chat box, or you could just unmute yourself and ask a question if you would like. We actually have had a question come through. Can you clarify what is meant by action plan 1 to 3 months, action plan 6 to 12 months, etc.? Does that mean a CDM plan is due or has been done, or something else?
So it's not so much about the CDM plan. It's really more like an asthma cycle of care or a diabetes cycle of care. That's the way I think about it. It's really the clinical guideline of, you know, what sort of monitoring and management should a patient with CKD have, depending upon what stage they're at. I'll just see if I can get back to that slide. So that's the report in CAT. Here we go. So it's really clinical. It's not exactly the MBS item, right? But obviously you could use the MBS item, for example, the GP management plan. You could do reviews of that throughout the year. You could use the nurse 10997 item number to ensure that all the items are attended. But it's not exactly the MBS, it's clinical. Does that make sense?
Kim's probably just needing a few minutes to reply.
Yeah, that's cool. Does that make sense, Jenny? That it's not
absolutely
exactly the item, it's more clinical, but yes, you should be remunerated for doing the do, for sure.
Thanks so much, Deb. We've had lots of thank yous and very helpful webinar today. Okay. Everyone will see that I've put the Slido link in again, so please give us your feedback because it helps us plan our education for future masterminds. All right, don't forget this is recorded and there will be a copy in our education library on the PHN website. I think, can we get a link to the recorded session? Absolutely. I will send it out to everybody.
That's excellent, Jenny. And also too, you know, persons could contact their primary care improvement officer, like they've all been trained in this, such that they can help practices to interpret their dashboard and, you know, navigate in CAT 4. So yeah, don't be shy about coming forward. That's why we're here, is to help.
Thanks so much, Deb, and thanks everybody, and we'll catch you next time. Bye-bye.
Thanks, Jenny. Thanks everyone for coming. Bye now. Bye.
Thank you. Thanks. Bye.